Hello, welcome everyone. While we wait for more people to enter this expo session, I would like to remind everyone that November is Epilepsy Awareness Month. This year, our campaign is focused on encouraging people impacted by epilepsy to speak about their experiences through the Silence the Stigma campaign. If you haven't already, please visit efmn.org to find out more information. In addition, the Epilepsy Foundation of Minnesota continues to provide one-on-one support through our information services. Since we are unable to meet in person, we do have virtual appointments available. You can schedule these appointments on our website. We will continue to support individuals through phone calls and emails as well. So this is an additional service during this time. With that, I would like to thank everyone for joining us for the Innovations in Epilepsy and Wellness Expo. I am Nikki Baker, Program Director at the Epilepsy Foundation of Minnesota. Today we welcome Dr. Atkinson from the Minnesota Epilepsy Group to speak about intractable epilepsy and give an overview of treatment-resistant epilepsy and associated areas to keep in mind. Before we start this session, I would like to go over some housekeeping information. For this webinar, your cameras and microphones are hidden, as the focus will be on the speakers and presentations. Following Dr. Atkinson's presentation, we will have a panel discussion with Dr. Atkinson, Dr. Thomas Henry, and Dr. Rob Das to talk more about today's topic. We will close with a Q&A session where you are able to ask questions to our experts. You will see a Q&A icon on your Zoom toolbar, and you can ask your questions there throughout this session. Now, before welcoming all of our speakers, I would like to introduce today's moderator, Dr. Thomas Henry. Dr. Henry is an adult neurologist and epileptologist who practices at the University of Minnesota Medical Center and clinics, and at Invasive Epilepsy Care. He is a professor of neurology in the University of Minnesota Medical School. He graduated from medical school at Johns Hopkins University and completed his training with an epilepsy, EEG, and neuroimaging fellowship at UCLA. His research has included seizure and epilepsy diagnosis, particularly using brain imaging and EEG techniques, and therapy, particularly with new anti-epileptic drugs, epilepsy surgery, and chronic neural electrical stimulation, and has over 100 publications in these fields. He is also the director of the Epilepsy Fellowship Training Program at the U of M. Thank you, Dr. Henry, for moderating our session today. Welcome.
Yes, thank you for this invitation. Well, I'm pleased to introduce Dr. Paul Atkinson, the speaker for this session. Dr. Atkinson is an adult epileptologist at the Minnesota Epilepsy Group, MEG, and is board certified in both neurology and epilepsy. He received his undergraduate degree at Colorado State University and was engaged in research in developmental neurobiology at Colorado State, the University of Utah, and the University of Minnesota before entering medical school at the University of Wisconsin in Madison. He completed his medicine internship and neurology residency at the University of Arizona School of Medicine, including a year as chief resident. He then continued work in central Wisconsin for several years before moving back to his home state of Minnesota to work at MEG in 2013. Dr. Atkinson is the medical director for the adult epilepsy program as well as EEG services at MEG. He enjoys spending time with his wife and 3 sons, particularly camping and hiking, and is an avid sports fan. Thank you, Dr. Atkinson.
Good morning. Thank you for that introduction. I appreciate being on this with both Dr. Henry and Dr. Doss, who will join us later for our panel discussion. So what we'll do is we'll go ahead and get started with the presentation. And essentially the topic of today is to talk about intractable epilepsy. Next slide, please. First, I wanted to start though, because I think it's real important for us to recognize the value of the Epilepsy Foundation of Minnesota. If you go to national meetings, it's amazing how the reputation of our Epilepsy Foundation here in the state is so strong. They're really looked up to as a model for a lot of other states to try to match. Their mission statement is listed there, and I just want to, again, applaud all the activities and really the benefit they provide to all patients with epilepsy and their families. So thank you. Next slide, please. So what we're going to talk about today is first just defining the term intractable epilepsy, and then we'll talk about the epidemiology of that as well. Then we'll move on and talk about evaluating patients with intractable epilepsy, what types of testing may need to be done to try to help figure out how to best help them with their seizures. We'll review available options for treatment of intractable epilepsy, and then we'll spend some time talking about some other important considerations that are outside of simply seizure control. We'll also talk about kind of when to seek care at an epilepsy center. You know, it's important for you, I think, for people with epilepsy to understand the options available at some of these specialized centers in terms of options for treatment and kind of a real comprehensive review of their epilepsy. And then again, at the end, there'll be a panel discussion with questions. So intractable epilepsy, the definition, we'll start with the one that's put forth by the International League Against Epilepsy. And what they define this as is when a person has not become seizure-free or stayed seizure-free with adequate trials of at least 2 anti-seizure medications. They also indicate that these medications have to be appropriate for the patient's seizure type. We'll talk a little bit about that again in the future. Must be tolerated by the person and can be tried either alone or together with other seizure medicines. What's important is when we talk about being tolerated by the person, we're not talking about being on one medication, having side effects from that, and then having to switch to a second medicine. We wouldn't consider then that first medicine to potentially not have worked for their epilepsy, but just needed to be changed because of side effect concerns. Next slide, please. And I think what's important is just to talk about some terms that mean the same thing. So when we talk about intractable epilepsy, you might hear other people use these other terms listed here, which are synonymous and absolutely the same. So intractable epilepsy, medically intractable epilepsy, refractory epilepsy, medically refractory epilepsy, drug-resistant epilepsy, pharmacoresistant, which is again similar to drug-resistant epilepsy, and Nikki even put another one on there that I should put, which is treatment-resistant epilepsy. So all of these terms really mean the same thing in that a person with epilepsy is on medications, but despite that continues to have problems with seizures. Next slide, please. This next graph is a really important one, and it comes from some studies published by Kwan and Brody back in 2000. And what they were looking at is what is the likelihood of someone who is diagnosed with epilepsy responding to medications. And what we can see on the pie graph in the middle there is that the biggest chunk, that dark blue area, which is 47%, that's the number of people who become seizure-free on the first medication that's chosen. Doesn't matter which medicine we're talking about. but just as the physician puts them on a medication, and 47% of those patients then will become seizure-free on that first medicine. If that first medicine doesn't work, and again, in this case, we don't mean related to side effects, but they get up to a good dose of the medicine, and despite that, they're still having seizures, and they move to a second monotherapy drug, so now on a second medicine by itself, another 13% of patients will become seizure-free. And if that medicine doesn't work, and we either look at a third monotherapy agent, or we start to combine therapies together using multiple agents to try to control someone's epilepsy, we'll pick up another 4% of patients in terms of helping those patients become seizure-free. What that means in the end, though, is that we're left with that kind of purplish area in the left side of the graph, where 36% of patients, despite being on multiple medications, continue to have seizures. And so that is really the definition of intractable epilepsy. And so overall, a third of patients with epilepsy end up with that type of diagnosis. Next slide, please. What's important to know is that Quan and Brody really looked at all types of epilepsy, and you know, epilepsy is a very large umbrella term under which there's a lot of different things in terms of how patients are affected by their epilepsy. If we look at epilepsy such as idiopathic generalized epilepsy, and that's where someone can have seizures where seizure activity begins on both sides of the brain at the same time, their epilepsy is typically a little bit more easily controlled with medication, meaning that the number of patients who aren't able to be controlled with medicine and are intractable is closer to 10 to 20%, which is certainly much better than the 36% from the last slide. And I've listed some of the potential diagnoses that are associated with idiopathic generalized epilepsy there, though there are certainly others as well. Then there's also the other spectrum where there are epilepsy syndromes where intractability nears 100%, including some of the neonatal myoclonic encephalopathies, Lennox-Gastaut syndrome, Rasmussen encephalitis. And so again, even though overall we can say it's about a third of patients, it does depend somewhat on what type of epilepsy that you have. Next slide, please. The other thing that can contribute to a patient seemingly to have intractability are other factors, meaning that if we tried to address these factors, might it be that they actually have epilepsy that could be controlled with medicine? And so what are those contributors? Number one can be the wrong diagnosis. So sometimes people can have episodes that look like seizure, but turn out not to be seizure. And certainly in that case, then treating with more seizure medicine isn't going to help. Sometimes people can be on a medication that's not the right medicine for their seizure type. So we just talked about those type of idiopathic generalized epilepsies where seizures again are on both sides of the brain at the same time. And if a medication like carbamazepine or Tegretol is chosen to treat those seizures, oftentimes they can actually make those types of seizures worse. Sometimes people come and they're just on not the right dose of the medicine, so they may not be on enough medicine to really control their seizures. We have some patients who may miss doses of medication and then have breakthrough seizures associated with missing doses of medicine. And again, when they take their medicine regularly, their seizures are well controlled, and so not truly intractable. And then there's also some lifestyle factors that can contribute to some of our patients having breakthrough seizures, including things like sleep deprivation, alcohol overuse, and other drug use. And it's amazing, you know, to me, every year I'll have some patients who, you know, are having some difficult to control seizures. And by making some of these lifestyle modifications, in particular in relation to alcohol, I have, again, handfuls of patients every year that can become seizure-free just by making those lifestyle changes. Next slide, please. So what are the risk factors for developing intractable epilepsy? Some of the factors that have been seen in some of the research papers include having a higher number of seizures before the epilepsy diagnosis is made and treatment started. Patients with focal epilepsy, or seizures that begin in one part of the brain and then can spread from there, have higher rates of intractability compared to idiopathic generalized epilepsy like we discussed. Again, certain epilepsy syndromes can have higher rates of intractability. If someone comes in and their first seizure presents as status epilepticus, which is a seizure essentially that does not stop, again, it's a much more severe presentation, and they have higher likelihood then of becoming intractable. And again, not responding to that first seizure medicine chosen, again, is a risk factor for intractability. Next slide. And just to show this one more time to kind of put it into your brain, Again, and you can see if that first medicine chosen doesn't work, then that's why it's a risk factor for becoming intractable, because the data really shows that the subsequent medication trials are less effective in getting someone to be seizure-free. Next slide, please. So this is a graph that was published in 2018, which looks at essentially the release dates of the seizure medicines that are available. And this graph is a couple years old, so there's a couple more medicines that really should be on there now. But I bring this up because if we think about that paper from Kwan and Brody, it was published in the year 2000. And they're looking at data from the previous several decades. And so if you look at the top part of the graph, those third generation ASDs or anti-seizure drugs, the ones in green, were really released in that time frame where their paper was coming out. And so one of the questions was, well, with all these great new medicines that we have, does that change that graph in terms of having less people that are intractable with their epilepsy? Next slide, please. And so the same group actually extended their research. This was published in JAMA in 2018. And unfortunately, what was found is that even though some of the newer seizure medicines have improved tolerability, and a lot of them have less medication interaction concerns, it didn't really change the number of people who developed intractable epilepsy. And so again, there's been benefit from these medicines in many different, for many different reasons. But again, doesn't change the fact that a third of our patients that we try to treat are still going to continue to have seizures despite medication. And so what are the options? Well, certainly one of the options is to try another medicine. And I put the picture on the right there just because I know some of my patients feel like they're already taking so much medicine that that discussion is hard for them to have. And again, if we kind of look at that graph that we saw on the previous page, there's low success rate, right? And we know that if we have somebody that's already not been helped by a couple of medications, the likelihood that the next medicine is going to help is very low. That being said, every time a new medicine comes out, and I have tried these medicines on patients, and I'm sure Dr. Henry would have the same experience, some of these new medicines, again, just are the right medicine for that person. And so even though the rate is low, we still try. Because we do have patients that can be significantly benefited by some of the new medicines that are released. So if we start to say, okay, what other options are there besides medications, then we're going to talk about the following. One is surgical resection, meaning, is there a part of the brain that can be taken out or ablated to try to help stop someone's seizures from happening? And we'll talk about some of the implantable devices that are out on the market now, including vagal nerve stimulation, responsive neurostimulation, and deep brain stimulation. We'll talk about who those are approved for and what benefits they may have. And then we'll talk a little bit about dietary therapies that can be used to try to help treat epilepsy as well, with the caveat that I'm an adult epileptologist, and these are tools often used by my pediatric colleagues. So again, that it might be, I don't have as much personal experience, I should say, with those. So let's talk about surgical resection. And really, when we think about doing surgery, where we're trying to take out or ablate a part of the brain where seizures are coming from, we really have to know a couple of very important things. Number one, do we know where the seizures are coming from? And that's where a lot of the tests that we do help to pinpoint the seizure onset zone. And number two is, what is the function of that area in terms of what kind of deficit or what kind of side effects could somebody have if we opted to remove that area of brain. It's not uncommon that if seizures are coming from a part of the brain, that part of the brain just isn't functioning well. And so we have lots of patients that can tolerate surgical resections without difficulty. But again, there's a lot of testing that goes into trying to evaluate that. In particular, what we're concerned about is making sure we're not affecting someone's language function, motor function, and memory. So the first step typically is to do what we call video EEG monitoring. And this is where someone will have an elective admission to the hospital. So it's scheduled ahead of time, not an emergent admission typically. And then they're connected to video EEG. So they have an EEG wires on the scalp and they're monitored on video the entire time. And because our goal in this setting is actually to record seizures, we'll often reduce patients' medications down to provoke seizures so that we can capture those. On the right side of the screen is just a snapshot of what an EEG can look like. And in this case, I did color code the EEG so that the blue lines are from the right side of the brain, the red are from the left side of the brain. And what you can see is that in those top part of the blue waves, where it gets sharply contoured, is a right temporal lobe seizure that happened in that patient. And what are the goals of this type of evaluation? Number one is that we want to record multiple events, because we don't want to make a surgical decision that we understand where seizures come from if we've only recorded one seizure. And so typically we're looking at recording 3 to 5 seizures, and sometimes more, depending on the clinical situation. The second part is again, when we talked about that potential for apparent intractability, is we want to make sure that the diagnosis is right. So sometimes we have patients that are referred in because they have continued episodes of losing consciousness and falling down to the ground, might be associated with some shaking. And sometimes we figure out that it's a different medical issue, not related to seizures at all. And again, seizure medicines won't help in that situation. So we want to make sure that the diagnosis is correct. And again, we have some people that might have a history that makes them at risk for having seizures come from 2 parts of the brain or more, related to some of the temporal lobe epilepsies. Patients that have had a history of an infection of the brain that caused their seizures, or a traumatic brain injury. Sometimes multiple areas of the brain can be producing seizure activity. And if we think about when we're doing that type of surface EEG, you know, we have the electrode that's glued down to the scalp. You don't have to have your head shaved or anything like that. But that one electrode is recording from probably an area about 4 centimeters, maybe up to 6 centimeters in over the surface of the brain. And so even though it does help significantly in terms of identifying where seizures are coming from, sometimes it's not enough for us to really feel that we have precise localization to be able to make those decisions. And so it's not uncommon that we'll have a second admission where patients will have an invasive EEG monitoring. And this is where electrodes are either placed surgically onto the surface of the brain, or the electrodes are inserted into the brain. And this allows us again to have a much better idea of where seizures are coming from, and can look at spread of the seizure as well. And again, this can be really important to try to really figure out where seizures are coming from in a lot of our patients that are pursuing a surgical option. And so this first slide, talking about invasive monitoring, is talking about what we call grids and strips. And so this is kind of the classic way that invasive monitoring has been done for quite a long time. In this case, patients have what's called a craniotomy, meaning that the neurosurgeon will cut a flap out of the bone, expose the brain, and then put a grid on, like you see in this picture on the left, which would be covering the area determined by the epilepsy doctor in terms of where they think seizures are coming from based on other data, in terms of what do the seizures look like, what does the surface EEG show. And so the placement, again, is going to be in different parts of the brain or different sides of the brain, depending on the patient's presentation. So you can see the square grid that's there. There's also those strips that extend more to the front part of the brain or to the right. So those strips allow us to expand and look at some of the spread of seizure activity as well. And again, these electrodes are on the surface of the brain. Occasionally there'll be some depth electrodes that might be used too, but primarily this is again recording from the surface of the brain, not from inside the brain. And I tried to incorporate pictures to kind of give an idea of what it'll look like implanted into patients without using any type of diagrams or pictures of the brain itself, in case people are squeamish at all. And so I figured that X-ray films would be the best, because this really shows well where the electrodes are. And so the picture on the left is just a plain film looking from the side. And so essentially we're like looking at somebody's ear, and we can see the grids that are placed there. At the top, you'll see, I guess I can't point here, but above where the circles are, you see those lines up and down. Those are staples from the patient's surgery. So they had the bone put back in and closed back up, and they were brought up to the floor so we can do this recording. The picture on the right is just now looking as if the patient or person is facing us. And again, you can see that the majority of those electrodes are on the surface of the brain. And in this case, the patient did have a few of those depth electrodes into deeper portions of the brain as well. There's a second type of invasive monitoring that has become much more predominant in the last decade or so. And this is called stereo EEG or SEEG. And this is much less invasive. So instead of having a craniotomy where the surgeon has to cut a large bone flap off to place a grid, in this case, there's actually very small holes that are drilled through the skull to allow electrodes to be inserted. And so this allows us again to identify where seizures are coming from or the seizure onset is, but also really lets us look more broadly at the spread of the seizure activity as well. There are some other added benefits. One is that this really does allow us to look at seizure onset that might be deeper in the brain. So again, you can imagine if we have an electrode on the surface of the brain, but the seizure is starting very deep, those surface electrodes, again, are not as beneficial as if we can have an electrode that's much closer to the onset. The other benefit is that we can do bilateral implantation, meaning that for some of our patients, again, we may have a concern that they may have seizures coming from potentially both sides of the brain. And whereas with the grids, we can't do a bilateral implantation, we can with SEEG. And again, this is much better tolerated, and so patients recover faster, and again, just is, I think, overall easier for patients to tolerate. What this picture is showing is a paper that was published in Neurosurgery in 2014, and it just gives a sense of some of the different ways that these stereo EEG electrodes may be placed. And so this is, again, some cartoon drawings of the brain. The black dots are indicating where the electrode would be placed. And so essentially, if you think about taking a pin and putting that pin right in that black dot, that's the same as what the neurosurgeon does in terms of placing those electrodes through a small hole that's drilled through the skull. And again, depending on what type of epilepsy or what type of seizures the patient has, we may have to explore different parts of the brain. And so, for example, in the top left picture, you can see there's 7 electrodes in that picture, and they're all isolated into the temporal lobe. So this is a person who has suspected temporal lobe epilepsy, and that was the placement selected by this surgical team. Whereas if you go all the way over to the right on the top row, you'll see that there's, let me just orient you that the front of the brain is to the right on that picture, the back is to the left. And in this case, they've done much more electrodes because they're trying to explore more areas, and they're looking in the posterior parts of the brain. So again, depending on what type of seizures you have, what the symptoms are when they first start, that's going to determine where the electrodes go. And similar to the grid picture, this is just a plain film that looks at those electrodes. And so what you can see is that there's no staples in this one, again, because there's no craniotomy that has to be done. And these electrodes can be placed very precisely, and again, allow us to then investigate where seizures are coming from. So that's first step, really, again, we talked about is EEG. And what EEG is looking for is the electrical changes that happen in the brain associated with seizure activity. And so we're trying to record electrically, where does it look like seizures are coming from? Well, the other tools that we look at to try to, again, identify what's happening in the brain, imaging plays a very big predominant role. So MRI really looks at the anatomy of the brain, not the electrical activity. And it's important to know that not every MRI machine is the same. So when we talk about the strength of the magnet that's used in an MRI, there's a term called Tesla, which is essentially the measure of the strength of the MRI. And the stronger the magnet, actually the better pictures we get, better spatial resolution we get of these potential findings that we might see in someone with epilepsy. And so, you know, at most of the epilepsy centers, patients are getting what's called a 3T MRI scan or a 3 Tesla MRI, which gives very good images. And what's been shown is that sometimes those 3T MRI scanners can pick up lesions that weren't seen on a 1 or a 1.5 Tesla magnet. And so it's been a very important tool in epilepsy to try to help identify lesions better. And now there's experimental machines, including a 7T magnet, such as at the University of Minnesota, which again is kind of expanding that to where I think we're going to be able to see smaller lesions that we never were able to see before. And I'm excited to see hopefully that come into clinical use as well. There's very specific sequences that the radiologist will use to evaluate patients with epilepsy. So that's why it's important to have your neurologist or epilepsy doctor involved in that so that they get the right pictures taken. And it's also important to know that even if you have epilepsy, and potentially even if you have intractable epilepsy, the MRI scan can be normal. And so patients are often surprised by that when they are diagnosed with seizures, and they assume that we're going to be able to figure out exactly what's going on based on an MRI scan. But again, those scans can be normal. So these next couple of slides are just showing some examples of what we might find in terms of abnormalities related to seizures and epilepsy. So in this first panel on the left, mesial temporal sclerosis is one of the most common reasons why people can have focal seizures coming from the temporal lobe. And in the picture below, what you can see is that the blue arrow is pointing to a normal hippocampus. So the hippocampus resides right where that is pictured there. It's in the temporal lobe. And if you look on the other side, where the red arrow is, that's the same structure. And so typically, it should look like the blue arrow on both sides. But in this person, the red arrow is pointing to the fact that the hippocampus is smaller, meaning that it's atrophied or shrunken down. And again, is a hallmark of what we can see with some temporal lobe epilepsies. The next panel on the right, labeled A and B, is looking at what's called a cortical dysplasia. And if you look at the arrows, the white arrow on the section A is pointing to this abnormal gray matter. So what you can see is if you kind of compare the side where the arrow is to the side where the arrow isn't, you can see that there's that extra signal of gray tissue there, which is brain tissue that essentially has not migrated to the right spot. And then by using a different pulse, a different way that they pulse the magnet to get different types of pictures, that same person in section B there just shows a different type of image that shows it as a bright signal. And so using these MRI scans, sometimes we're able to find these small areas of abnormal brain development, which are commonly associated with seizures. And here's a couple more. One is related to stroke. So it's not uncommon that we can see patients that have stroke subsequently go on to develop problems with epilepsy. And so that is showing a stroke that is old, meaning that this stroke happened at least probably 6 months ago. And what we're seeing is that the area of the brain that used to be there where that dark signal is has now been taken away by cells that repair damaged tissue, and it's filled in with fluid. And so again, it's not uncommon that we can see seizures in the tissue surrounding this type of stroke. And on the right panel, we see someone who has tuberous sclerosis. And what we're looking for on this one is that you can see kind of on the outside parts of the brain, there's some areas where there's a little bit brighter signal, most prominent in the far right picture. And those are tubers, which are, again, abnormal areas of brain development, which oftentimes are associated with seizures as well. There's other types of imaging tests that we do, again, to try to look at where seizures might be coming from. So this is called PET scanning, or positron emission tomography. And this is where glucose is labeled with a tracer that can be imaged. And if we think about glucose, so that's really important for all functions of the body, but in particular, the brain uses quite a bit of the energy that you use in a day just because it has such high functioning. It gets about a third of the blood flow because it requires so much glucose or sugar for it to function normally. And so when we label glucose and then look at where it goes in the brain, what we're looking for is there any areas where there's hypoactivity, meaning are there areas of the brain where it seems like less glucose is being used than what we'd expect? And this is always performed with EEG on at the same time. And essentially, the panel on the right then shows a result of this type of testing. And the color, the brighter, the warmer. So the orange, the reds are higher areas of glucose utilization or use. And as you kind of go down, we're kind of scrolling down to the lower parts of the brain. And then if you get to the bottom row, in the middle there, you see the one white arrow. And if you compare where the white arrow is pointing to the same structure on the other side, you can see the other side has a brighter signal and a much lower or blue signal where the arrow is pointing, indicating an area of hypometabolism, or an area again where the brain just isn't quite functioning correctly. Next slide, please. The reason that it's important that we have EEG on is because if someone has a seizure during this type of imaging test, it can vastly change the results. And so in this paper published in 2013, they just showed a picture on the left there in panel A, where you can see the white arrows in the lower corner pointing to an area that is, again, lower in metabolism. So it's those greens and blues as opposed to the other side, which is more the yellows and reds. And that's what we call interictal, or between the seizures. So this is what we're really trying to capture with the PET scan. But on the right panel, labeled B there, is what we call an ictal PET, meaning that the patient had a seizure while this scan was being done. And what you can see, that same area, instead of being low in metabolism, is high in metabolism. And that makes sense because if you think about what a seizure is, it's an increased hyperexcitability. All those neurons are firing. And so they're using a lot more glucose during that. And so again, the outcome of the test is dependent on whether someone had seizures or not, which is why it's important to do EEG when the test is ongoing. One of the other imaging tests that we do is called magnetoencephalography. And this is, again, looking now at more at the electrical activity as opposed to the anatomy. And essentially when spikes or abnormal electrical activity happen in the brain, it causes a change in the magnetic field. And so we have a MEG machine, and this is actually Dr. Zhang, our neuroradiologist, that helps us with these type of tests. And it can, again, help us identify where discharges are occurring. And this is a non-invasive way to look at some of those potential deeper areas where seizures are coming from, because this allows us to look into the deeper parts of the brain than EEG does on the surface. And we can also use this test to try to help identify where language function is, where motor function is, and where sensory areas are. Because again, if we're trying to think about surgical options, we need to know not just whether seizures are coming from that area of the brain, but what functions does it have? And then Dr. Zhang can take these information that we get and co-register on the MRI scanner, essentially layer an MRI and then put this information from this testing over the top to again allow us to try to identify where seizures are coming from and where someone's language, motor, or sensory areas are. And we're fortunate here in Minnesota that we do have this machine available. This is a map from the Association of MEG Centers. And there's quite a bit, so the pink color is where this technology is available. And you can see that there's a lot of places in the US where this type of testing isn't available. So we're fortunate to be able to have it here in Minnesota. Another type of imaging scan that is done is called a SPECT scan. And this study is done in the hospital setting. And that's because what this does is, again, it labels an isotope that is injected right when a seizure starts. And so it's really important that the injection times are kind of within 10 seconds of when that seizure first starts. And then they are taken down to radiology and they do an imaging test, and they are looking for, again, this increased blood flow. If you think about that PET scan where the patient had the brighter signal associated with their seizure, again, because there was more glucose utilized in that area of the brain when the seizure happens. So similar with this, there's increased blood flow to an area where there's a seizure happening. The isotope accumulates more there. And so this can help identify in some patients where seizures are coming from. So we've talked about electrical activity, which is looked at with EEG and also magnetoencephalography, looking at the magnetic fields. We've talked about some of the imaging tests that look at structure and function, such as the MRI, some that look at the physiology, such as the PET scan and the SPECT scan. And now we're going to move on to looking at cognitive testing. And so what's really important is that all the epilepsy centers where this type of evaluation is performed have neuropsychologists working with us. And we're fortunate to have Dr. Das with us here today, who is one of, I think, the premier neuropsychologists in the nation. I'm biased because I work with him, of course. But again, it's really important that we're not just looking at where do seizures come from, but looking overall at how a person with epilepsy is doing from a cognitive standpoint. Some of the testing can be done to look for such things as side effects of medications, which again is important and may help us change someone's regimen to something that they tolerate better. But in the context of looking at a surgical resection, again, what we want to do is make sure we understand, the area of the brain that we're looking at that we think seizures are coming from. What are the potential results of taking that part of the brain out? And so again, we're looking at things like memory, motor function, but in particular with neuropsychological testing, they can kind of walk through all the different areas of the brain and really identify where problems might be, looking at processing speed, perception, reasoning, judgment, some of the things listed here. What's important too is that sometimes the results can be used to try to help patient know where their strengths and weaknesses are. So if someone finds out based on this testing that they're a much better visual learner, meaning they have to see something to be able to have it get into the brain and have it be remembered, as opposed to someone who might be more auditory, hearing something. Those types of things can be important just so that you understand for you how you best take in information and can help with some of the cognitive troubles that people have related to memory if they understand the best way to take that information in. What's important too is that there's a psychological assessment with this type of testing as well. And that's because there's high rates of depression and anxiety that come on with patients with epilepsy as compared to people that don't have epilepsy. And those types of symptoms of depression and anxiety can impact cognitive function. And so it's important for us to identify as well. And again, this type of testing is imperative to have in the setting of evaluation for epilepsy surgery, because again, if we can identify what parts of the brain aren't functioning well, that can sometimes help us with seizure localization. And again, the next step of that is our neuropsychologist can also help us identify what cognitive areas might be impacted if we decide to try to take that part of the brain out. And what's helpful is that sometimes repeat testing over time can really evaluate trends and can identify changes that happen post-surgically as well. Another test that we do, which again can help us identify the risk in terms of taking a part of the brain out, is called a Wada test. And this is named after Dr. June Wada, who was the first person that performed this procedure. And essentially, what this is there's an injection of a medication that will essentially put half the brain to sleep. And so there's other names for this test called the ISAT or the ISAP that you see there. The sodium amylbarbital is the name of the medication that's used. And what happens is this is done typically in a neuroradiology suite where there's a catheter that's placed into the groin, and the radiologist sneaks that catheter up so that it's into the carotid artery in the neck. And then they infuse this medication, and the carotid artery mostly will affect one half of the brain. And so essentially we're trying to put half the brain to sleep, which would allow our neuropsychologist then to test the other part of the brain that's awake. And so patients are awake during this testing, and we're putting one part of the brain to sleep and testing memory function and whether they can identify and name objects that are shown to them. The medication actually reverses pretty quickly. And so we can put one half of the brain to sleep, stop the infusion, let the medication wash out, and then about 20 minutes later, we're able to do the same type of testing on the other side. And so in this way, we can isolate whether someone has a dominance of language on the left or right. We can identify whether someone has memory function that might be real strongly supported on one side or the other, or sometimes both. And again, this type of information is imperative to understand when we're thinking about things like temporal lobe surgery in particular. EEG is done while this is going on, mostly because we can tell when the medication is working, because if you think about half the brain going to sleep, all those brain waves that are normally functioning when you're awake all of a sudden get real slow. And we do motor response because we have the patient squeeze our hands to really test when the medication is not working anymore, because we want to not really then look at data beyond that point. We can do similar things with functional MRI. And this is certainly newer than the Wada in terms of availability. And again, it's using an MRI scan while patients are doing testing of language function, hearing stories, moving a finger. And again, we can help to identify where language, motor function, and sensory function is with imaging studies as well. And so what's important to know is that really what I've tried to do is give an overview of all the different testing that's out there that may be helpful in terms of identifying where seizures are coming from, what type of effects you might have if a surgical resection is performed. But what's important is that it doesn't mean that everybody needs all those tests. And so, again, your epilepsy physician, your epileptologist is going to look at your case, look at the symptoms that you have, look what your seizures are like, look at the data that's available to decide what testing may be necessary. So again, there's a lot of options out there to look at things, but not everyone needs every test. And again, really the goal of all this is to look for what we call concordance of data, meaning all the data that we're getting, we really want to point to one area of the brain as the cause, meaning that on the EEG, let's say that someone has a right temporal lobe epilepsy. We want the EEG to show us that seizures come from that area. We want the MRI scan to show us that there might be some changes in that right temporal lobe. We want our cognitive testing to perhaps show that there's deficits that coordinate or correlate with a right temporal lobe lesion. Because that gives us a chance then to say, yes, everything looks like it's coming from this right temporal lobe, and we think we have a good chance of improvement of seizures by taking that out, and a low likelihood of causing any concern from a cognitive standpoint. If someone's EEG points to problems here, and the MRI points to problems here, and the neuropsychological testing shows global issues, those patients are much less likely to be successful in terms of surgical resection. And so, again, all this information is used to decide whether someone might be a candidate for this type of surgery or not. And then typically what's done is that there's what we call a surgery case conference, and there'll be different names at different institutions. But essentially what this is a multi-specialty conference. And so I'll talk specifically what happens at our institution here at MEG. So this is a conference that happens once a week. It involves all the epilepsy doctors we have. So we have 10 epilepsy doctors in the room, including both adult and pediatric epileptologists. Neurosurgery is present. We have our neuropsychologists like Dr. Das present to help us understand a lot of the data related to cognitive issues. We have neuroradiology there, both Dr. Zhang, who works with our group and helps us with the magnetoencephalography, but then radiologists as well from the institutions that we work with. And we have psychologists that are present and know the patient's case as well. And essentially what we do is we lay out all the information about their history in terms of when seizures started, what medications they've been tried on, and we walk through and actually visualize patients' EEGs. We look at the seizures that they've had. We look at all the imaging studies that have occurred. And again, talk about the neuropsychological testing that's been performed, talk about psychological status, and review any of those imaging studies that might have been done. And essentially, after presenting all that information and having sometimes robust discussion, a consensus is obtained, meaning that out of this conference of all these specialists, a recommendation is going to come out for what we think are the best next steps for that patient to try to help with their epilepsy. And this graph is just kind of giving a broad overview of the potential outcomes. And this is from a mix of many studies. And so on the left side, what you can see are whether someone has been seizure-free from the procedure, whether they've had their seizures improved in terms of number or not improved at all. And at the top, we'll start with temporal lobe surgery, which has the highest likelihood of making somebody seizure-free. And again, 23% will see improvement in this, but again, there can be cases where patients don't see improvement. Outside of the temporal lobe, the rates of seizure freedom are less, unless, and the next one over, lesional, meaning that there's an abnormality on the MRI scan where we can see that there's a specific area of the brain that we think might be causal for seizures. Again, the rates of seizure freedom are higher and rates of improvement are higher, but again, not every lesion is associated necessarily with causing someone's seizures, and so we can see people that don't have benefit. Corpus callosotomy is where we actually take the fiber band, nerve band that connects the two sides of the brain and can be severed. This is typically done for patients with some of the catastrophic epilepsies where they might be having lots of drop seizures, where they fall down to the ground and are at risk of injury. And by doing the corpus callosotomy, we can hopefully stop those drop seizures from happening. And so seizure freedom rates are lower, and that if it happens, that's great, but that's usually not the initial goal. Really what we're trying to do is improve the severity of the seizures that are occurring in those patients. There's a newer technology that's been out now for about a decade, and this paper was actually just published a couple of months ago. And that is using what we call laser interstitial therapy, where there's heat generated by a laser to ablate a part of the brain where seizures might be coming from. So instead of a craniotomy, there's a port that's inserted into the brain where the seizures are coming from, and the neurosurgeon can plan out the trajectory of that, apply heat with the laser to ablate again where the seizures are coming from. Again, this was just published in 2020. The NeuroBlade system that was used, I'll just put out a plug that it's a Minnesota company, so that's kind of cool. And they did 60 epilepsy, did surgery on 60 patients enrolled with epilepsy, and 64.3% of those patients were seizure-free at 1 year. Again, this is a very specific technology that's used for small lesions, so we can't do large lesions or large resections with this type of device. And so, again, it's used in very specific populations, but there's advances being made in surgery that are less invasive, and I think that's important for people to know. So someone can go through this entire evaluation and workup, which takes a lot of time and a lot of investment on the patient's standpoint. And at the end, it may be that they're not a candidate for surgical resection. And that may be that our consensus conference says, yes, we think it's a great idea. We think you should have this type of surgery. We think it gives you the best chance of not having seizures. But that person may not want to have surgery, right? Seizures may be multifocal. So again, if we identify that seizures are coming from more than one area of the brain, you know, we're not going to go in and take out multiple pieces of the brain because we're much more likely to see cognitive difficulties associated with that. And so if we're seeing seizures coming from 2 areas of the brain, a surgical resection is typically not performed. The data also may, again, not predict a good outcome. Like we talked about, we're looking for concordance where everything is pointing to one part of the brain as the cause. And if the data shows, again, that there's diffuse areas from a cognitive standpoint that are affected and the MRI and the EEG don't correlate in terms of areas of concern, then the likelihood of a good outcome is less. And sometimes we're able to very specifically pinpoint that people's seizures do arise from an area of the brain, but we can't take it out because if that part of the brain is right where your motor cortex is, and we took it out, you'd be paralyzed on one half of the body. If it's in your language area, you might be unable to speak or be aphasic. Or if you rely on one part of the brain for memory and we take that part out, that obviously would be a major concern as well. And so, again, if you have seizures arising from these type of eloquent cortex, resective surgery is not going to be the recommendation. And then we've talked in the earlier portion of the discussion today about idiopathic generalized epilepsy. Next slide. And this is an EEG of somebody that has idiopathic generalized epilepsy. And what you can see is that this is an EEG. This is a 10-second span across the page and includes both electrodes from the left side on the top part and the right side on the bottom part. And what you can see is that in the first few lines there, the EEG is a normal background. And all of a sudden you see these really high amplitude or what we call spike wave discharges. And what you can see is that they're really coming from every part of the brain. And so again, in these idiopathic generalized epilepsies, there isn't one spot to go take out because again, the epilepsy is generalized. And so resective surgery would not be an option in these type of patients. So what options do we have then? So we've talked about the fact that we can try medications. We can try more medicines. We talked about trying to look at whether surgery is an option. But if surgery is not an option for resection, what other options are there? And so what we'll talk about next are implantable devices. And you can see the 3 devices that we're going to talk about listed there. And I think what's important to know is that really the goal of this is seizure reduction. So we don't typically go into one of these discussions talking about devices with the promise or expectation that it's going to make somebody seizure free because the likelihood of that is low. However, by improving seizure control, we can oftentimes improve quality of life. And we can do it with these devices without adding a medicine. And so we're not adding to that medication burden in terms of side effects and such. So VNS was the first device that was approved in the 1990s. It's an option for both focal as well as generalized epilepsies, okay? And that's important to know because this is really the only device that can be used for idiopathic generalized epilepsy. Interestingly, this device is also approved for treatment of refractory depression. So again, a separate indication for the device that's used. And if you think about a vagal nerve stimulator, and we'll show you some pictures about what I mean here, but we're not trying to figure out where the seizure starts because this is a stimulation that happens outside the brain. And so you don't necessarily need to have invasive monitoring or those types of tests to have this device implanted. What this picture shows is essentially what the device looks like. And so on the picture on the left, you see the bigger circle that's in the anterior chest of the patient. That's the generator or battery. And from that, there's a wire that wraps and goes up around the vagus nerve in the neck. And so what you can see is that no part of this device is actually in the brain itself. Next slide. And there's 3 different types of stimulation that the vagus nerve stimulator can do. And so what you saw pictured on the previous slide with the device going on and off all through the course of the day, that's what we call normal mode stimulation. And that's programmed by the epilepsy doctor. Typically, when it first goes on, the patient might be stimulated for 30 seconds and then off for 5 minutes. What that means is for about 10% of the day, the device is stimulating, and for 90% of the day, it's not. And it's really this type of stimulation, is what is really responsible for the reduction in seizures that we can see with this device. There's a second type of stimulation called magnet stimulation, and there's a picture of one of the magnets that can be used. Where essentially if a person feels like an aura or a seizure coming on, or if a family member sees a seizure happening, someone can swipe this magnet over the device and it'll actually trigger a stronger and longer stimulation with the goal of trying to reduce or stop that seizure from happening. And some of my patients, this is a really important strategy for them because it's really helpful. But unfortunately, for many patients, the magnet doesn't do that much for them at all. And then the third type of stimulation is newer. So when the VNS came out in the 1990s, it didn't have this availability. This just came out within the last 5 years or so, which is something called autostimulation. What we can see is that when someone has a seizure, it's very common that their heart rate will increase during that seizure. And so what they've done with this device is that it's right next to the heart where it's implanted on that left side. And so the device can detect pulse rate. And if a pulse rate goes up very quickly, we can use that sometimes as a marker that a seizure may be happening, and then apply again an extra stimulation. So that happens automatically, doesn't require a magnet or any intervention by anybody around the person. It's just a setting that we can use on the device to, again, give a longer and stronger stimulation with the goal of trying to reduce or stop that seizure. So what this shows on the graph on the left is some of the original data from when the VNS was first approved. And what we saw is that at the 3-month mark, which is the green bar, there was a 23% responder rate. And I need to just define what a responder rate is. So it's a common term that's used in epilepsy research. And a responder rate is defined as a 50% reduction in seizures or more. And so what that means is that 23% of patients at 3 months had at least a 50% reduction in their seizures. And what they saw is that over time, that improved. And so at 1 year, it was 37%. And then in these studies, it plateaued at 43% in year 2 and 3. There's been quite a few more studies published subsequently looking at longer term use. And I can say on average that about half of our patients that get a VNS have about a 50% reduction in their seizures. But it's a bell-shaped curve, meaning that there's some patients that have a much better response and some patients that have no response at all. And unfortunately, there's no testing we can do ahead of time to try to identify who might be a great responder and who may not. In some of the longer term studies, if someone is benefiting each year, they might see a little bit more benefit, even sometimes 70, 80% reduction in seizures. And there's a recent study published in 2016 where someone looked at their case series and found that about 8% of their patients became seizure-free. And again, I think it's important to point out, again, the goal of this type of device is to reduce the number of seizures that are happening. The likelihood of seizure freedom is low. But again, for some patients, this can be the right thing that makes it so that they're not having seizures anymore. The second device was the RNS system, and this was approved by the FDA in 2013. This device is implanted in the brain. And so this is a device where it's very important for us to understand where seizures are coming from for it to be able to work appropriately. What essentially happens is that there's a generator or a battery pack that's implanted into the surface of the skull. And then off of that, there's electrodes that go either onto the surface of the brain or a depth electrode that can go into the brain, into the area where seizures are coming from. And this essentially records EEG information. And then what we do is we train the device that when it starts to see a seizure happening, it provides a stimulation with the goal of aborting or stopping that seizure activity. There's an ability for people who have this implanted to upload information from home. I'll show you a picture of that. The epilepsy physicians can review this online. And what's important is that right now, you can have two different electrodes. And so for someone who does have seizures coming from two parts of the brain, its potential, the ability to use this device to treat both is there. And in fact, the company is exploring trying to get even up to 4 electrodes that can be used for stimulation. This is just a cartoon looking at the device itself. And so that big silver thing on the top is again implanted into the skull. They actually carve out the bone a little bit, so it sits relatively flat, so it's not something that can be seen from the outside at all. And then from there, in this picture, they show 2 different electrodes. So they show the one that's at the back part of the head, where it's going into the deeper parts of the brain. And then there's the one that's more of a strip at the bottom, kind of curving around the underside of this person's temporal lobe. And again, because this is implanted in the brain, what is given to the patient is a wand where they can upload this information online, and it'll store what we call corticography, or this EEG data that we see. And we use and evaluate that data to try to figure out and adjust the paradigm of the patient's detection of their seizures and also the treatment of their seizures. So what this picture is kind of showing the loop that's used. So at the top are the pictures of the brain with a device implanted labeled A, B, C, and D. And on the bottom is the corticography, or the EEG data that's recorded from the device, also labeled A, B, C, and D. And so those letters coordinate to each other. So in panel A on the left, you see the light blue signal going back to the RNS generator, corresponding to normal activity seen in the bottom panel. In panel B, seizure activity has started, and you can see in the picture B above, that red signal going to the generator is detecting that seizure. And then in panel C of the picture, what's happening is the generator now is producing an electrical signal. It goes through those electrodes, and that's why it looks flat here on the bottom panel. And what you can see is that this was a successful stimulation and that the patient's seizure stopped because of the stimulation that kind of broke up that seizure pattern. And so again, what we do is we train the device to recognize for that person what their seizure looks like on an EEG. And when the device starts to see that pattern develop, a stimulation is given to try to stop the seizure. This is just a kind of a closer up picture of the corticography data that we can see. And in this top one, what you can see is that the labeled left hippocampus. So this person had a electrode in the left hippocampus and then also on the right hippocampus, R hip. And in the top panel where it starts to turn blue, where there's a lot of spikes just on that top of the 4 lines, is seizure activity starting in the left hippocampus, which was treated by the device. And then the bottom panel in the same patient, you can see right hippocampus, and then there's a red square around on the right side where a seizure develops. And so in this person, they had seizures coming from the left hippocampus and the right hippocampus. And because this device can stimulate and treat 2 different areas, was a great option for them to try to help reduce seizures. And if we look at seizure improvement over time, again, this is pretty common that we see with a lot of the stimulating devices that the improvement occurs over the course of years. And so if we look at the first year after implantation, the median percent seizure reduction was 44%. And over time, it got up into the mid-60s. And patients would report that they did have seizure-free intervals, meaning that they had, for instance, a 3-month time frame or less without seizure, 3 months or more of seizure freedom in 37%. 23% said they had seizure freedom for 6 months or more, and about 13% for a year or more. And so again, the focus really is on that this can really drastically improve the number of seizures that are occurring, but again, not as likely to make somebody seizure free. The last device was approved in May of 2018 and really is derived from technology that's been present for a long time to actually help treat Parkinson's disease or essential tremor, and that's deep brain stimulation. There was a trial, the Sante trial, that was done, and actually the results of that trial allowed for this to be improved many years earlier, both in Canada, Europe, Australia, and several other countries, but was kind of delayed in approval here in the US, again, just here in May of 2018. This also is approved for focal onset epilepsy, but this, again, is not being placed where seizures come from, so it doesn't require real precise seizure localization like the RNS system does or surgical resection may. The electrodes are essentially placed into a part of the thalamus, which is a deep structure in the brain, and in particular the anterior nucleus of the thalamus. And by targeting this area, we can see a reduction in seizures. This is just, again, a picture of what the device looks like. Again, a generator into the under the skin in the left chest. And then it has extenders that go up into under the skin. So this is all internal. Nobody can see any of this from the outside. And then electrodes are implanted kind of at the top of the brain, down deep into that deep part of the brain called the thalamus. And so on the right side, what you can see is that anterior thalamic nuclei. It's right in the middle. And essentially, that's the target of the RNS. And what this is pointing to is that there's this circuit, meaning there's kind of this circular connection between all these different brain portions, into the frontal lobe, into the fornix, the hippocampal formation in the temporal lobe, the amygdala. And so again, by stimulating this anterior thalamic nuclei, our goal is not necessarily to stop the seizure where it starts, but to disrupt the spread or the circuitry that's involved in that seizure. And again, this was the Sante trial. And again, they used responder rates, which is again that a 50% or greater reduction in seizures. At year 1 was 43%. And as you can see over time, again, got up into the low 70% reduction in terms of seizures. So now we've talked about surgical and ablative options for patients. We've talked about implantable devices. And again, for the implantable devices, the VNS is the only one that would be approved for generalized epilepsies. Otherwise, all the devices are approved for focal epilepsies. VNS is approved in pediatrics above the age of 4. Unfortunately, right now, the indications for RNS and DBS are for patients that are 18 years of age or older. So next, we'll move into dietary options for intractable epilepsy. And we'll talk about, in particular, the ketogenic diet and the modified Atkins diet, and just briefly mention these other two. So the ketogenic diet was first reported in 1921, and it's been primarily used in children. So it's not a common thing used in adult epilepsy programs. And essentially, this is a significant change in a person's diet, so that they're taking a high ratio of fat and protein as opposed to carbohydrate. And so 90% of the person's caloric intake for the day is derived from fat. And it's usually combined with some calorie restriction, so on a little bit less calories for their weight than they would typically need. Occasionally, some people will have a benefit with a 3-to-1 ratio, which might be better tolerated, but again, may not be as successful in terms of controlling their seizures. This type of diet also requires very precise counting of calories, really counting the amounts of grams of fat and protein and carbohydrate, and dietitian support is really critical for this to be effective. There was a study done, published in 2006, looking at a large number of patients treated with ketogenic diet. And so they looked at a total of 860 patients. And you can see the mean age there was essentially 5 years old, close to 6 years old, with most of the patients in that range from then, 3 to 9 to 10 years old. Of those patients, 422 were able to adhere to the diet. And of those patients that were able to successfully stay on the diet, 83% of them achieved at least a 50% reduction in seizures. 52% had more than a 90% reduction. So it's a very effective treatment. And in fact, 24% complete seizure control. The problem is that the tolerability leads to a high dropout rate. For some patients, again, so 438 patients dropped out of the study, either because of ineffectiveness, potentially the diet being too restrictive. There can be some illnesses and side effects from the diet that make it so that it's not able to be done. Poor compliance. So again, if you are on this diet and suddenly you eat a piece of cake and a lot of carbohydrate, it can completely reverse the metabolism that's been generated by the diet and lose effectiveness. And some patients, again, were just what we call lost to follow-up, meaning that they didn't continue in the trial and it's not known the outcome of how they did. There have been some trials done in adults. And again, because the diet is so restrictive, if you're able to walk to the fridge and get your own food, it's tough to follow something like this. But in this case, they did 12 patients, 8 women, 4 men enrolled, and 3 stopped within the first 4 months. 2 were for psychosocial reasons early on in the study, 1 person for lack of efficacy at about 2.5 months. In the other patients that completed the trial, 5 patients had a greater than 50% reduction in their seizures, and 3 patients had a greater than 75% reduction. Then there's a second diet, and this kind of came out of more of a weight loss diet called the Atkins diet that was really famous, 20, 25 years ago. So this was primarily used for weight loss, but what we found is that patients with epilepsy that were also trying to lose weight and using this diet sometimes reported that their seizures were better. And so a different diet was generated called the modified Atkins diet, which is essentially the Atkins diet, but much more restrictive on the amount of carbohydrate. This one, there's no weighing of food. You don't have to count as closely in terms of caloric intake and grams per day. So a little bit more flexibility. And there was some trials published both in adults and in kids looking at the modified Atkins diet. The one on the left panel here is looking at a prospective study of 30 patients enrolled that were adults. So the median age was 31. You can see the range of the patients was 18 to 53 years old. And prior to starting the diet, on average, these patients were experiencing at least 10 seizures per week. 8 of these patients had prior epilepsy surgery. 12 of them had VNS already implanted, meaning that obviously they were still having seizures to be enrolled in something like this. 20 remained on the diet for 3 months or more. 14 completed the whole 6-month trial. So again, if you kind of think about 30 starting out and only about 50% completed the trial, again, there's some difficulty maintaining this type of diet therapy. But of those that did complete the trial, most of them continued the diet after the trial stopped. And again, there was some improvement reported in terms of seizure control. In the right panel is looking at a randomized trial, meaning that, and this is in pediatrics, where patients were enrolled in the trial and were randomly placed either on the ketogenic diet or the modified Atkins diet. And what they found in this trial was that, particularly in kids ages 1 to 2, the ketogenic diet had demonstrated superiority, meaning that much more of the patients became seizure-free and was clinically significant. In all the other age groups, there was a trend towards the ketogenic diet being better, but it wasn't statistically significant, meaning that even though the percentages looked a little better, scientifically, you couldn't say that one was really truly better than the other. There's a couple other diets that are out there. One is called the MCT diet, where much of the calories that are derived from this and fats are from MCT oil. This one does allow for a little bit more protein and carbohydrate. Again, there's modified portions of these diets that are less restrictive and better tolerated. There's also the low glycemic index, where we're really focusing on reducing carbohydrates as the primary goal, again, which each of these has some data to suggest they may be helpful with seizures and epilepsy, but I don't think robust trials have been done at this point. And what this graph is looking at is just kind of giving you an idea of these diets and the effect on kind of the food that you're eating. And so the boxed area is all the diets we talked about. So the ketogenic diet, the modified Atkins diet, the low glycemic index diet, the MCT oil or the medium chain triglyceride diet, as compared to the one that's outside the box, which is kind of a normal standard American diet. And in that normal diet, what you can see is that a large proportion of everybody's calories on a daily basis really comes from carbohydrates. And if you see that yellow kind of greenish area, and you're looking in these in the diets, you can see that, again, carbohydrate intake is significantly restricted, particularly in the ketogenic diet and the modified Atkins diet. So I think, again, when we're talking about patients with intractable epilepsy, our focus can't just be on how many seizures are you having side effects. Those are hugely important questions, but there's a lot of other things that are important to talk about too. And one of the things that we see is that there tends to be much higher rates of mood disorder in patients with epilepsy, but the risks are even higher if you happen to have intractable epilepsy. And so this was a study published in, sorry, there's a misprint there, 2013, where they looked at rates of depression, and they found in healthy controls, about 8.8% of people had depression, and the rates you can see there are much higher for intractable epilepsy. And the same thing is seen for anxiety. Having intractable epilepsy in our adult population also affects ability for employment and being able to sustain employment. Household income tends to be lower. There's unfortunately a large degree of stigma and discrimination that can happen in patients with epilepsy, and that's one of the major fights that the Epilepsy Foundation takes on. There can be more social isolation, increased risk of injury. If you're having seizures and falling down, there's higher rates of injury that can be associated with that. And quality of life measures tend to be lower in patients with uncontrolled seizures. SUDEP is important to talk about too. So we're talking about sudden unexpected death in epilepsy. So this is something where we just know that patients having generalized tonic-clonic seizures have a higher rate of potentially dying from their epilepsy. And in someone just in general that has epilepsy having generalized tonic-clonic seizures, the rates are about 1 in 1,000. But in someone that has intractable epilepsy, unfortunately, the rates of sudden unexplained death are higher. And so what I think is most important is that really, when we're talking about seizure freedom or reduced seizures or side effects of medicine, depression, anxiety, all these symptoms, what we're really focused on is quality of life. That's really the most important factor overall that we're looking at. And so if we look at epilepsy centers, there's the National Association of Epilepsy Centers that defines essentially the level of expertise of epilepsy centers. So level 1 essentially means the emergency room or your primary care office. Level 2 is where you might see a general neurologist and they might decide to do an EEG and put you on medication. But epilepsy centers level 3 or 4 are actually accredited by that national organization. And it means that they provide higher levels of service. And essentially with a level 3, we're talking about potentially doing some straightforward epilepsy surgery, but those that don't require any of those invasive EEG monitoring like we had talked about. And they might do something like VNS, but they're not doing DBS or RNS. Whereas level 4 centers have the highest level of accreditation by the National Epilepsy Association. And that's where essentially all of these tests and everything we've talked about are available. The experts are there, both in terms of the epilepsy docs, the surgeries, neurosurgeons, the neuropsychologists, and can provide a really broad range of epilepsy care, looking both at seizures, seizure numbers, potential for surgery, but also providing that psychosocial support as well. And so the recommendation from the National Association of Epilepsy Centers is that really if you are seeing a general neurologist and your seizures have not been controlled or brought under control after about 12 months, that's when you should be really seeking referral to one of these specialized epilepsy centers. And we're fortunate here in the state of Minnesota to have a plethora of options. And so my group at the Minnesota Epilepsy Group, University of Minnesota, where Dr. Henry is, the Mayo Clinic, all these centers are level 4 and provide care for both pediatric and adult epilepsy patients. And Gillette Children's Specialty Healthcare is a level 3 epilepsy center for pediatrics. And so in summary, what we did today is really discuss what is the meaning of intractable epilepsy and the fact that about 1/3 of patients with epilepsy are going to be defined as intractable. We talked about some of the tests that can be done to try to optimize seizure control and some of the treatments that are there to improve seizure control, including surgery, implantable devices, and some of the diet therapies. We talked about these other important factors. So assessing and treating depression and anxiety, focusing on that quality of life measure is very important. And those options are best addressed at one of our epilepsy centers. And I thank you very much.
Hey, thank you, Dr. Atkinson, for that excellent talk. You generated some questions that I've been monitoring in the background here, which I'd like to address to the panel. So a number of the attendees sent in questions, which of course are anonymous. We're not going to be reading off the person's name who asked the question. And I also want to note that we have a panelist joining us, Dr. Robert Doss, who's a clinical neuropsychologist and director of psychology services with the Minnesota Epilepsy Group, where he's practiced for over 20 years. He's also an adjunct faculty member with the Department of Neurology at the University of Minnesota. He has experience in conducting clinical research studies in neuropsychology and behavioral health, and has authored over 30 papers on neurobehavior and neuroimaging of epilepsy, dementia, and concussion. Finally, he is a past board member with the Epilepsy Foundation of Minnesota. Dr. Doss, thank you for joining us. So we had a number of questions in each part here. And one that I wanted to loop back to at the beginning that Dr. Atkinson had already addressed, but this is asking more of a question about timing to get to one of the level 3 or level 4 epilepsy centers. And there's a very specific question as to when a person with epilepsy or the parent of a child with epilepsy should seek a referral from a general neurologist to one of the epilepsy centers.
Yeah, so I think that's a very good question. And, you know, we're fortunate here in the Twin Cities to have these epilepsy centers here. So we have some patients that come to us directly when they first are diagnosed with epilepsy. But I think in terms of, again, if you or your child is seeing a general neurologist and it's been more than a year and seizures are still happening without control, then that's really the time frame where we should be requesting a referral to one of the epilepsy centers here.
Yeah, good. And then there was a broad question on non-medication treatments before we'll maybe loop back to some of the very specific questions about particular treatments. But this broad question is, who would be a good candidate for epilepsy surgery versus VNS, RNS, or DBS?
Yeah, another great question. And I think, you know, the answer is that our primary focus is usually on trying to see, is there some type of resective surgery that we can do or ablative surgery that we can do, because that's our really one chance to really try to impact someone's seizures and potentially make them seizure free, even though they might need to continue on seizure medicines. But that type of resective surgery is our one chance to try to see, can we actually stop seizures from happening in that person? For some people, again, they don't want to go through that type of procedure, and then one of the devices would be an option. Or again, if we decide that that type of surgical resection isn't the best option, then that's again where we'd look at some of the devices.
And I wonder, Dr. Doss, if you would have any additional comments on that. If we have somebody who, you know, knows that they haven't gotten seizures controlled with medications, but they may not have completed the Wada test yet, or, you know, all of the other detailed testing, is there anything in terms of cognition, memory, personality, anything that would make you favor a particular therapy to focus on?
Well, I think that it's important to understand, and Dr. Atkinson actually talked about this a little bit, is to take a look at a person's life circumstances and and try to understand, is there anything in their life, for example, depression, anxiety, or if there's any use of drugs or alcohol, that those are things that could potentially impact their seizure control. And so certainly from the standpoint of the psychologist or neuropsychologist, you want to get those things taken care of and assessed properly and treated, because those are definitely things that can impact a person's seizure control.
Yeah, good. So then we had a number of questions that are more specific to particular therapies. So one question was about whether there are any particular techniques to avoid language or memory deficits with the resective epilepsy surgery.
Sure, and again, Dr. Atkinson touched on those, and so I mean, the first thing that we start off with is a comprehensive neuropsychological evaluation where we're able to understand what a person's capacities are, what their strengths and limitations having to do with speech and language and memory, just at their baseline. And then there's a number of procedures once we move along the surgical evaluation path, such as the Wada test that was reviewed, where we look at memory capacity, we'll look at which side of the brain's speech and language functions are supported. The functional neuroimaging procedures that we have available with magnetic source imaging and functional MRI also give us indications about speech and language functions and where, not only which hemisphere they're in, but also potentially which where in the brain more specifically are those functions. And then finally, when we have the opportunity to, a patient has either SEEG or grids placed surgically, we can do stimulation mapping where we actually try to interrupt speech and language functions and get a much more exquisite map of where those functions reside in the brain and how they are, where they are related to the seizure foci.
So then the results of that stimulation mapping would really allow the neuropsychologist to help the neurosurgeon to avoid critical locations. Is that right?
Yeah, that's exactly right. So we were able to really draw up a map of where the extent of the speech and language functions are, as much as the grid and the SEEG can tell us, and then inform the neurosurgeon and the epileptologists about those regions, and so they can plan the surgical extent of surgical resection and also the approach of the surgery as well.
Yeah, good. Well, that was a complete answer. So we're now officially past our cutoff of 11:30, and I just want to warn people in case they had other meetings or things they need to do. And the Epilepsy Foundation will make the entire recording available to everyone. So even if you're not able to stay past 11:30 here, please send an email to the staff at the Epilepsy Foundation, and you can hear the rest of the panel answers here. Okay, so those were the main questions we had on that particular therapy. There was, for several people, a concern about possible adverse effects of the ketogenic and modified Atkins diet, particularly with regard to whether there'd be a risk of these diets causing kidney stone formation or increasing atherosclerosis, hardening of the arteries.
Yeah, and I think that, again, I'm going to put out there that it isn't a therapy that I do personally, so I don't have as much experience. So Dr. Henry, please weigh in if you'd like. There is increased risk of kidney stones. There's metabolic issues that are caused by this diet that are important for seizure control. But again, because of those high rates of fat intake, cholesterol is certainly monitored in patients that are on this. It's less of a concern in kids. And again, most kids, if they're on this diet, are not on it for their entire life. It's usually for potentially a few years. And again, it's, I think, a bigger concern in the adult population, just because, again, the risks of cardiovascular disease are higher And we just don't have enough patients that have done these type of therapies in the adult setting to be able to answer those questions. But we would monitor closely, and I agree with the concerns raised by the participants.
Yeah, I agree with that. So then we have several forward-looking questions about perhaps expected improvements in efficacy, better seizure control with new research for resective epilepsy surgery, for devices that cause stimulation, and also for anti-epileptic drugs. And one person in particular was asking about the long-term impact of staying on anti-seizure medications while waiting for these improvements, but continuing to have seizures during that time.
Yeah, and again, that's a great point, because when we talk about seizure medicines, we can't just be talking about seizure control. We have to be thinking about all those effects that these medications can have. Again, part of the benefit of some of the newer medicines that have been put forth is that they do have less side effect concerns, especially with long-term use. We think about medications like phenobarbital or Dilantin or phenytoin, carbamazepine. We know with those medicines that they can have some long-term effects, particularly in areas such as bone health, causing osteopenia or osteoporosis. Phenytoin can cause some other issues with long-term use in terms of affecting balance issues and such. And so certainly if you're going to be on medications long-term, again, being seen at an epilepsy center where they can try to get you on the best medication combination possible while you're waiting for new therapies to come out would be of benefit.
And I think this person was also trying to get at the possibility that there might be some sort of damage or injury by allowing oneself to have ongoing seizures while waiting, instead of maybe getting seizure control with surgery or a device.
Yeah, again, a great question. So the concern is, when we look at an individual seizure, we don't think that an individual seizure on its own causes a significant amount of damage. The problem is that if you have seizures ongoing for days and weeks and months and then years, that certainly we can see some cumulative effects of that seizure burden in terms of some cognitive changes that can be measured over time. So I agree, again, the difficulty is that we do have patients in this category with intractable seizures, where they're still having seizures, and we're looking at all these options for treatment. Unfortunately, if seizures do continue, there are concerns about continued cognitive issues over time.
So, Dr. Das, do you have any comments on that with the risk of cognitive injuries with ongoing seizures?
I'll also add that with continued seizures and less control, there's always the risk of status epilepticus and having more significant prolonged seizures. And we've definitely seen in those cases the more of a stepwise change in cognition. And so we, of course, want to try to prevent that as well. But indeed, we know that important factors that predict cognitive functioning later on is related to the frequency of seizures that a person's having, the duration of the seizures that they have, and so that's very important in relation to kind of ultimate cognitive outcomes.
So I think we had a failure in transmission at the end of your answer. So I think we missed about the last sentence or two of your answer. Sorry.
Certainly, the higher frequency of seizures that are individuals having, the type, if they're frequent generalized seizures, can certainly impact negatively on cognition. And so we definitely want to try to treat that and minimize that, of course, because it can have cognitive impacts down the line.
Okay, good. Yeah, I think the transmission was held up during part of the answer. So what I got is you're particularly concerned about the seizure types, the generalized tonic-clonic versus partial seizures that are going on, and especially the risk of status would considerably increase the risk of a permanent deficit. Is that right?
That's correct.
Yeah.
That is correct.
Okay, well, thank you. Okay, and then we had one general question I could put out. I think that maybe isn't just specific to these areas of therapy, but one of the listeners wanted to ask about what the impact of puberty is on seizure patterns. So.
Yeah, so, and again, we talk about epilepsy being that umbrella term. The answer is going to be very different depending on the seizure types that you have. When we talk about effects of puberty, the type of epilepsy that can have be affected the most by something like that would be the idiopathic generalized epilepsies. You know, we have some kids that may develop absence seizures, and then as they hit puberty, those resolve. And so it's really with those idiopathic generalized epilepsies that we have the potential for puberty having an effect. We can see in other types of epilepsies though, and this is again not specific. I can have someone that kind of presents with the same history, and sometimes seizures might worsen or seizures might get better at times of puberty or in women of menopause. And so there definitely can be hormonal effects on epilepsy control. And there can be a pattern in some women that they have more seizures around their menstrual cycle. And again, those are important facets to understand because there's treatment that can be directed towards those specific patterns if they're occurring.
Okay, so I think this discussion is stimulating some more questions. So let me add on a couple more here that just came in. So I think these are pretty specific on therapies and diagnostic tools. So one of the questions was, is PET scanning as good as stereo EEG for planning epilepsy surgery?
Yeah, and I would say that unfortunately, PET scanning is pretty limited in its ability to give us information. SEEG is really highly focused in terms of identifying where seizures come from and patterns of spread. The PET scan just isn't very robust in terms of localizing areas specifically. If you kind of think about some of the pictures we'd show, you know, some of those dark areas where the metabolism was lower were quite widespread in those parts of the brain, not very focal at all. And so the PET scan is more of a additional tool that can sometimes help us, particularly with temporal lobe epilepsy. But SEEG certainly is much better in terms of identifying where seizures are coming from and better identifying options for surgical intervention.
And then one other question on stereo EEG, specifically, do the holes in the skull that are made to insert the electrodes close up, or in other words, heal over?
They do. So there's again, the long-term complications related to SEEG are very small. You know, again, the healing is very much quicker than the large incision and craniotomy that's done with the grid testing. So again, patients recover very well from SEEG.
Okay, and then finally, one of the attendees shared an experience with epilepsy and the impact of relatively later in life referral to an epilepsy center that I think really raises the question, is there an age cutoff for considering epilepsy surgery or stimulation devices?
Yeah, and I would say no, in the context that it does get a little bit more complicated if people have other medical issues going on. So if you have a lot of comorbid medical conditions, the risk of any surgery is higher. And so we have to think about that in the context of thinking about these types of procedures. But there have been studies performed in patients 60 and above showing that there's been significant benefit in terms of seizure control and quality of life with low impact side effect wise in terms of helping patients with epilepsy. So I would not say that there's a ceiling in terms of consideration. with, again, comorbid health issues being one of the major variables that could affect that decision.
Dr. Doss, what do you think? Are there risks that are different for cognitive outcomes doing a resection in older age versus younger age?
We really haven't seen that. So I'd kind of echo what Dr. Atkinson said. It's been more related to medical variables than cognitive issues. There hasn't been a lot of evidence to suggest that the older folks who get epilepsy surgery or other surgical treatments fare worse than younger participants.
Good. Thank you. Well, looks like we don't have any more new questions at this point. So, Nikki, I think we're probably ready to close.
Great. Well, I just want to thank each of you for attending today and sharing your expertise. I know I learned a lot, and so I would assume everyone did as well. I want to thank the Aduichi as well for fielding those questions. If we did not get to any of the questions you had today, or you walk away and you do think of other questions, please feel free to email us at admin@efmn.org, and we will work on answering your questions for you. I thank you again for everyone who attended, and we hope to see you on the upcoming sessions the rest of the week. Thank you.